We come to the last lecture of the day, which is Complications of Regional Anesthesia by Dr. Sandeep Diwan.
Good evening, everybody. Supposed to be the last of the lecture, so plenty of time for me. Even if you go, I'll be keep on talking. So take a deep breath because you have seen quite efficient blocks since morning by Dr. Bala, Dr. Gopal, Rushali, Silamban, and then Sunil Pandya. And there was a lot of rush at the stimulating catheter shop because Lakshmi was mentioned about the role of stimulating catheters. So they are also benefiting a lot. So let's see what happens now. And I would like to tell you a small story about complications in regional techniques, how it happens and how you should take care of this. Now, I have one of my friends here who practices in a small place from my region. My place is also small, too small than hers. And she called me up and she said that she has given intracranial block and the patient stopped breathing. So what must have happened? But she did one good thing. She had already intubated. She's Dr. Barge. She was here somewhere. And her orthopedic surgeon, he's also here. So I said that she said that it was a delayed sort of cessation of respiration, and she had intubated. The patient has become conscious and is moving her lower limbs, but not her upper limbs, and she's awake. So what could have been the result? I said, keep on ventilating for some time and just give me a call after 2 hours and see what happens. You will extubate at that point. So after 2 hours, she had extubated. The patient was awake and was ready to be discharged. So this was a classical subdural placement of the local anesthetic, which could occur in any of your intracranial blocks. So kindly be aware of this. This is not the reason, not to make you scary about blocks, but this is one of the things to be reminded. Somebody mentioned about in the morning about neuronal injuries. This is the anatomy of the nerve, and you can see very nicely. I don't have the pointer here. You can see, yeah. Hope it doesn't go to Delhi. So this is the anatomy of the nerve. This is the epineurium, which encloses the endoneurium, and this is the perineural space, and these are small, very small fascicles. So what happens? Now, most of the times when you give a local anesthetic, you are placing it in over where? Now, these are some of the extrinsic vessels which might get traumatized. I'm not bothered about this, even if it gets traumatized. But if your intrinsic vessels get traumatized, there can be a small hematoma in this, and this hematoma in a very small space, that is in this particular space, in the intravascular space, is going to cause a real compression of the fascicles. And a small increase in the pressure in the intravascular area is going to cause a large compression and is going to cause the neuronal damage. So be very cautious in placing your drugs. Now, this is the cross-section anatomy. You can see the epineurium, which covers the perineural space, and this is the intravascular. These are the fascicles, and this is the intravascular area, and this is the intravascular, and this is the interfascicular area. So you can place the drug either here, or you can place it in between the fascicles, that is interfascicular. Now, there are some reports, like Dr. Ashit and me, we are always in touch with each other, or Dr. Vinayak, he's also here. So we are always in touch with each other, and sometimes he says that the block is active for such a long time, almost 48 hours, he's not able to move his fingers. What is that? So this is a typical interfascicular placement of the drug, of the local anesthetic, and that is why you are getting a prolonged effect of the local anesthetic. It's not going to cause any problems, but you never know because you don't know whether it's really a interfascicular or intrafascicular. And when you place it inside the endoneurium, this is really going to cause a big problem. Now, there are several case reports where when you elicit paresthesia in the era where PNS was not available, and now when the PNS is available, if the patient is complaining of severe radiating pain across the limb, across the nerve, or in the intracellular trunk when you're trying to elicit paresthesia or neurostimulation, and patient complains of severe pain along the limb, it does mean that the needle might be inside the nerve, or it might be intraneural. So you have to be very cautious in these cases. So this was in the past, no paresthesia, no anesthesia. No paresthesia, no dysesthesia, but often filled anesthesia. So paresthesia is absolute now. When you're talking about any nerve block, always it is either a PNS guided or it's an ultrasound guided. we did few experiments. Dr. Desai, she is here, and her husband is an oncosurgeon, and we did few experiments here where I gave in the past, almost this is 6 years back, I gave a paresthesia elicited interscalene block. There was a small hematoma, and when he explored during the radical neck dissection, we found that there was a huge hematoma over here. And when he drained out the hematoma, we found that there were a lot of small hematomas which were still bleeding. So that is why there should be no multiple pricks. That is the reason why there was somebody mentioning about multiple pricks. So no multiple pricks, no paresthesia. So it's only peripheral nerve stimulation. This is a famous author, Silander, who has got who has done a lot of work, particularly in paresthesia-related complications, and he mentions that there should be no rough probing and there should be no multiple paresthesia. Admir Hadzik has done this famous study where he has applied intravascular injection of local anesthetic, and you can see what has happened. This is, of course, in an animal, and this is the intravascular injection where it has made a syrinx, and this is a needle entry track, and there you can see the bulging endoneurium, and this is how it has destroyed the nerve, in fact, one of the fascicles. So that is how it happens when you elicit a paresthesia. So, in one of my studies, what I did was I applied an ultrasound. I was trying to go towards the interscaling superior trunk, and then suddenly the patient complained of pain. I kept in the probe. I saw that almost the needle bevel was inside one of the nerve trunks. So paresthesia, it does mean that one of the component of the needle might be inside the nerve, and this could really cause a problem, because if you're injecting with such a needle, this is an 18 gauge 2E needle, and if you're injecting into the local anesthetic into the nerve, it can really cause problems. So paresthesia is now outdated. We are only going to talk about nerve stimulators and ultrasound. This author has mentioned that there is increased risk of failure with more than 0.6 milliamperes. What we do is, when we try to locate the nerve, we start with 1 milliamperes, and then we come down to 0.6, 0.5, 0.4, 0.3. So more than 0.6, there will be failures. And if you go less than 0.4, there is no further improvement of onset and quality. And this author has mentioned 0.1 to 0.2 milliamperes. This is very dangerous. Now, why this is dangerous? Because it has been proved in pigs that if you perform a neurostimulation at less than 0.2 milliamperes, you are likely to cause a lot of inflammatory process near the region of the nerve, and this could really damage the nerve in the post-block period. And that is why this is absolutely obsolete. So this was 0.2 milliamperes at 20 ml, which was given. At 0.3, 0.5, there was no sense of inflammation. So you always take PNS guided at 0.3 to 0.5 milliamperes. So 0.3 should be more than better. Pressure measurements. Now, when you are injecting a local anesthetic, this is the point. Now, I have stimulated the nerve trunk at 0.3 milliamperes, and after that, I'm going to inject, but I don't know where it's going at all, because there's no way, unless you place an ultrasound probe, that you know where the local anesthetic is going. So you have to always feel the difference in the pressures. Like, I have trained my theater attendants to know even the difference in the pressures. He says that this is not, the needle is not in the plane, sir. So I think you should change it. So that is how he can guide me even. So some of the intramuscular, perineural, intraneural can be easily suggested by yourself. Now, in one of the workshops which we were holding in Chennai with Dr. Silverman, we had a case where simple axillary block was to be administered. And when the performer was almost in near the axillary plexus, he said that I am feeling some resistance. And it was almost as spontaneous that I told him, I was thinking of telling him not to inject, but at that moment he injected. And few moments later, the lady was convulsing on the table. There was a good team who had immediately given diazepam and the thiopentone, intubated, and then the surgery was done eventually. But always keep in mind, resistance always in any of these regions is very dangerous, because this can cause intravascular injection. Always, I try to use this kind of thing. You use 2 10 ml syringes and a stopcock, so that you don't have to move the needle, and at the same time, you don't have to go on changing it, so that the needle remains at that particular point. Now, this is an important thing. This is the monitoring of the injection pressure, and this is from the site Nizora, and they have already mentioned that intravascular injections more than 20 psi. There is definitely histological evidence of injury to the nerve fascicles, and that particular gadget makes you very safe, because more than 20 psi, it definitely tells you that you are somewhere else. So complications in regional, this is a group from France where they have done more than 1 lakh studies, and they have found problems with interscalene, supraclavicular, axillary, and mid-humeral blocks. And they have found the cardiac respiratory rate, respiratory failure, seizures, and peripheral neuropathies. Not much to quote, but most of them they are found in the lumbar plexus block. You can see that figures over there, and very less with the sciatic blocks, of course. So complications related to cervical root blocks. Now this can be also an interscalene block also. Now this is the spinal cord, and that is the root which is going to come out. That is the vertebral artery. So the root is going to come here, vertebral artery is here. So the neck is such a structure we are going to give. It's so compact that it has got a gastrointestinal tract, a respiratory tract, a neurological and vascular structures all in one. So in such a compact structure, if you are going to put in your needle and try to elicit something and then give the drug, you might expect something else. So this was a patient who was supposed to go for a cervical neurolysis. It's a huge mass which was there. And when I inserted a needle into the neck, I found that there was blood at the end of the hub. Now this clip was taken by one of also my colleagues, Dr. Naz. She's not here, I think. So this is the classical picture of intravascular needle placement. And when we went for a scan, we saw that this was done on the scan. We saw that this was intravascular placement of the needle tip. Now this is a paravertebral catheter which was kept in place for pain relief, and this was actually for neurolysis. So that the needle was withdrawn. So it's important very much for you to have any modality like a CT scan or ultrasound for the placement of these needles. Once you give the drug, now this can happen also in interscalene block. You can see the contrast in the intervertebral foramen here, contrast in the intervertebral foramen, but this can also spread into the epidural space on one side. And if you're going to neuralize, like if you're going to use 100% of alcohol, you're likely to cause problems in the epidural space. So that's why you have to be very, very careful whenever you inject your drugs. So when complications occur, trying to place the needle tip too close to the nerve, inadvertent needle tip placements in the vascular lumen, and local infusions in the vascular area, like a paravertebral space. This can be as well as giving a local anesthetic in the intravascular area. Now I told you the neck is a very compact structure, and placing the needle can cause problems. And this is the cross-sectional view of the interscalene area. This is the interscalene area which is sandwiched between the two muscles. Now interscalene block I always consider as is also considered as a superficial block, which is not much of a problem. But when you start getting the needle over here and inject your local anesthetic, it can spread anywhere. It can spread to this phrenic nerve, which lies anterior, and cause phrenic nerve palsy, which is not a complication. It is a sequelae to interscalene block. It has to occur in most of the cases. I will show you a slide of that. Then it can also block one of the vagus nerves, which can cause bradycardia. I had that. Then it can cause blockade of the recurrent laryngeal nerve, causing hoarseness of voice. It can go on the other side and cause even euphonia. I had a patient who had euphonia for almost 24 hours, and all the time the relatives were asking me when she's going to talk. So it's very difficult to explain to them that the drug has gone the opposite side and it has blocked the recurrent laryngeal nerve on the opposite side. They are not ready to agree with this. So respiratory complications, hypoxia under interscalene. I had these patients. It's very important to know this. Unilateral bronchospasm, because you're blocking the interscalene on one side and you're causing sympathetic block on one side and oversympathetic drive on the same side, causing unilateral bronchospasm, and blockade of the sympathetic may cause, that is what I am trying to explain. So this can happen with you. I had a patient in whom I gave interscalene block. She was 50 years going surgery on the elbow, and she was quite comfortable. And then suddenly she started talking irrelevant. I never knew what had happened. I never looked at the oxygen saturation. Very important to note this. Put them on oxygen, put them on a saturation monitor, and always try to talk to them. These are the important things you have to keep in mind when you